Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts.
Hi, I'm Mike Gibson. Welcome to Factor XI inhibition, a new paradigm in stroke prevention. I'm joined by my good friend and colleague, Manesh Patel. Welcome, Manesh.
Thanks, Mike. Excited to do this conversation with you about anticoagulation therapy, and it's where we're going.
Well, let's look first where we've been, Manesh. And back, 1940s, heparin. Revolutionary at the time, comes from pigs, still comes from pigs. So that was our first shot at this. And then we had warfarin. The Wisconsin Agricultural Research Firm, developed this as, I hate to say it, as a rat poison. And we've been using that for a long time. But things changed in the 90s when we had the introduction of some drugs that ended up being safer. There was a lot of intracranial hemorrhage with warfarin. And these agents, like the DTIs, the Bigatran, apixaban, edoxaban, Factor 10 inhibitors, they were all safer in terms of reducing the risk of intracranial bleed. However, there were still some other bleeds, like GI bleeds, particularly for drugs, say, like rivaroxaban. So we didn't quite get there yet with respect to reducing all the bleeds that we want to reduce. And now that brings us to 2025, where we have Factor XI inhibitors. And this is our goal, which is to prevent those ischemic strokes, but also do it safely. And that's why people are actually very excited about this potential new class. So we still have high rates of non-major bleeds. We call it non-major bleeds. I got to say, Manesh, any bleed that happens to me is a major bleed. I think when you talk to a patient, this whole life, you survived the bleeding event. It wasn't major. No, any bleeding is kind of a major lifestyle issue for patients. So we really want to get that down. But we want to do it, without losing our benefits in terms of ischemic stroke. So we're hoping to walk the tightrope here by having something that's both safe and effective with this kind of new and emerging class. My son, Manesh, when I told him what we're working on, he just kind of rolled his eyes. And, he's a quantitative genomicist and oncologist. He said, Dad, what are you doing? Why are you doing these big trials? The trial has already been done. Nature's already done the study. And he literally grabbed my arm, walked me over to the computer. We got onto the UK Biobank, and here's what he began to see. That yes, people with Factor XI deficiency have lower VTE events, and they also have lower cardiovascular events. And he just said, well, maybe you guys are onto something. So, it met with my quantitative genomicist son's Mendelian randomization approval. So there's a good biologic reason why this might work. The other thing about these patients is they don't have a lot of spontaneous bleeds. And so it looks like a free lunch, reduction in thrombotic events without an increase in ischemic events, at least from the genetic and epidemiologic data. Now, you can have a lot of different factor deficiencies, but if you had to pick one, let's look at the red box. Factor XI deficiency has the lowest rate of those very severe bleeds. Maybe some bleeding with trauma, but not much in the way of spontaneous bleeds when you have Factor XI deficiency. So that makes it a very attractive deficiency to mimic with our drugs. Now, this is a chart that would make the hematologist's head explode. I mean, I've really kind of melted it down for people like me who went into cardiology.
Like me too. Yeah.
To avoid the complexity. I've tried to make it simple. So, look, we got two broad pathways here. There's the bad clots. Those are the ones that form inside your vessels, your arteries and veins. And those are inside the vessel. And that's why we call it the intrinsic pathway, the inside pathway. And some of it's mediated by contact activation when you come in contact with a foreign substance. That foreign substance in arteries tends to be the fatty plaque, the fat inside the plaque when you have plaque rupture. So you kick things off, you form a clot. That is where this drug is working. See that red block there? This drug is blocking that positive feedback loop so that when you begin to make thrombin, it feeds back to make more factor 11, 11A. And what we're doing is we're blocking that 11A. So we're blocking the positive feedback loop that causes a burst in clot. Now, let's look over on the other side, the blue side. This is the outside the vessel side, the extrinsic pathway. These are the clots you want. These are the clots that prevent you from bleeding. What you see here is that factor 11 inhibition does not block that pathway. So you can go from 7A to 10A and form a clot in that way without being inhibited by 11. So what we're doing here is we are dislinking the left-hand side from the right-hand side. We're allowing you to continue to form those good clots that prevent bleeding, and we're preventing you from forming the bad clots that prevent life, that clot up the vessel. So that's why we're very excited about this. Now, there's a lot of ways to skin the cat here. There's some antisense drugs being developed more and more. This turns off the sink. It turns off the production of factor 11. The other things that we see here, they kind of mop up the floor. If you have a flood, they're inhibiting factor 11 that's already been made. So two kind of different approaches. Aptamers, antibodies block the activity of factor 11 floating around in the molecules, as does the small molecules. The bottom line down here are these polyanion antagonists. We've just learned in the past few years that platelets release a lot of things that activate your clotting cascade. So there are these polyphosphates, there are these nucleic acids, these things called nets that we've been hearing about. They cause you to clot, and this class of drugs will block that kind of clotting. Now, very complicated diagram here. It looks like something an electrical engineer would design, but really just three main things that I want to take home. There are things at the very top here. These are drugs that are blocking the beginning of clotting, and that's where the factor 11 inhibitors are. They're way up at the top. Some are inhibiting 11, and some are inhibiting 11A, which is the byproduct of activating 11, and some are inhibiting both. So that works very high up in the clotting scheme. Then further down, kind of midway down, you see 10A there. That's where rivaroxaban, apixaban, and edoxaban are working, lower in the cascade. And the final kind of step in the cascade when thrombin converts fibrinogen to fibrin, that's where dabigatran, ergatran, and bivalirudin are working. It's very low down in that final common pathway. So what we're doing is we're working at the top. Manesh, when we were younger, we used to talk about the final common pathway, 2B3 inhibitors blocking the final steps. But you can also block the first steps. And so with this kind of drug, we're working up at the top to block the first steps in blood clot formation. So how is it different? It's allowing you to continue to clot the bleeders. It's not essential for hemostasis, this factor. We're decoupling bleeding and clotting. That's very good. We do have data from epidemiology and genetics that says, if you did the randomized trial in nature, randomized people to deficiency or not, the deficient people do better in terms of VTE. And there's a lot of populations out there that we could really use these kinds of drugs. There's a lot of foreign substances we put in people these days, everything from beds to hemodialysis to valves to left atrial appendage occlusion devices. We got a lot of contact activation going on. So in my mind, that is one group of people that are currently underserved that we could really do a better job with. There's kind of three horses mainly in the race right now, abelacimab, asundexian, and milvexian. Abelacimab is an antibody, fully humanized. Asundexian and milvexian are small molecules. The abelacimab inhibits both factor 11 and 11A, whereas asundexian and milvexian just inhibit 11A, the byproduct of activating it. You give abelacimab sub-Q or potentially IV. Asundexian and milvexian currently are oral drugs right now. With abelacimab, you get it once a month, long half-life. With asundexian, once a day dosing, very convenient. I know I take my meds once a day. With milvexian, it's twice a day. You take another dose at night. Rapid onset for all these, maybe a little more rapid with the orals, but slow offset with the abelacimab. No renal clearance with abelacimab, but a little bit of renal clearance with the small molecules. No drug interactions with abelacimab, a few with the small molecules. So some commonality, but some distinctions in these classes. So what are some of the limitations we're trying to fix here? The standard therapies we're using are underused, I think, because of bleeding risk. The goal here is to use a drug that preserves your hemostasis, but reduces ischemic events. So we hope to have fewer bleeds, less drug-drug interactions. Kidney function is so important, Manesh, in an aging population. We have more and more people with bad kidneys. And, we have to reduce the dose of drugs like apixaban and Riva and edoxaban in those people. So having a drug where we don't have to do that kind of dose reduction would be nice. So I think this is what makes the potential for this class exciting. So we have genetics, we have epidemiology, we have animal studies, all showing us, very positive insights in the potential mechanism and benefits of this class of agents. So, Manesh, we've seen that these factor 11 inhibitors in the earlier trials can reduce bleeding. What patients do you think might benefit the most from factor 11 inhibition? And, if a drug like this gets out into practice, what is the barrier to you adopting something out there?
It's a great question, Mike, and hopefully, the barriers will change. We won't have the same barriers we've had in the past where we've seen a 5, 10, often 15-year lag between something being proven and more than 50% of people using them. In part, it is because of things like this where there's a fear of some of the side effects or safety issues that might expect. This isn't really a side effect as much as a balance, as we've highlighted. I think, there's still a huge opportunity, as we've discussed, in people that are either scared and not taking this or failing, right? And they're failing because they tried it and they bled and they stopped, or they underdosed, or they're not getting maximum opportunity to take the right one. So for me, there's still quite a few people in our practice where the balance, as we've highlighted before, isn't perfect, and they're a little bit more on the risk of bleeding. Those are the elderly, the renal dysfunction patients, the patients that we're thinking about for these devices for atrial fibrillation, the patients that might have had a stroke or a bleed in the past where they're not sufficiently treated with the current therapies.
Really tough, isn't it, Manesh? I mean, in trials, someone gets in a trial and in practice says, well, nothing's happening. I guess I don't need the drug. Or if something happens, they said, well, the drug didn't work. I don't need the drug. Or I bled. And boy, I don't need the drug. So it's, getting people to take drugs is a big challenge. And it's not just the big bleeds, right? I mean, if you're an elderly woman and you start to have some nosebleeds or bruising, there's a tendency to say, well, I got 12 medicines I'm taking here. I don't know which one it is. I don't like that. That blue one is big. I'm going to stop the blue one and the yellow one.
Yeah.
And, based upon color and size, they stop their medicines. The next thing you know, they've fallen off the track of evidence-based medicine. So bleeding it's not like bleeding is directly killing you. It's, the Roberta Flack thing, it's killing me softly. You're taking away all of these other medicines that were actually, working together to save your life. So it's complicated. Now, let's wrap up here. So the mechanism is a new approach for Factor 11. It targets clotting while remaining you to be free of bleeds. So far, in animal studies, genetics, epidemiology, small trials, even big trials like one you led, look safe. But the big question is going to be efficacy. Are we going to preserve the effectiveness of what we've grown used to over the years? And that's why we're doing all these big phase 3 trials. So when we look more and more into this residual stroke risk, Manesh, how do you talk to patients about the benefits here, particularly people who may look like they're low risk on paper, but may still be vulnerable to recurrent events?
Yeah, thanks, Mike. I mean, I think part of the issue is just explaining risk to people, as you've highlighted, right? 1 or 2 or 3% stroke risk might mean something different to everyone. And so I think the first understanding, and there's a lot of conversation in the world right now about shared decision making, but the way I think about it is sharing information with the patient, understanding their values and wants, and then coming back with a recommendation on the best of our medical knowledge. And often what that means for a lot of individuals who think and feel like, oh, I'm not at risk. This is true for everything from high blood pressure to diabetes to AFib and stroke prevention. Unless you can feel something, you don't realize the underlying risk that exists with it. And so I often start with that sort of concept for people to make sure they understand that when you're thinking about preventive therapies, there's an opportunity there. The second after that is to use some of their own personal features that do increase their risk, even when they may feel or appear low risk. Often that's the persistence or very prevalence of atrial fibrillation. It may be in left atrial appendage that's, or at least left atrial size that's very enlarged. There might be people that also have, I've found a lot of people that have renal dysfunction that also have risks that are not thinking about the other risks. And so those are just some of the ones that we would talk about. And then if they have the existing concerns that many patients do around stroke and thrombotic risk, then we can talk about ways to try to reduce that.
Manesh, one of the problems with modern culture and modern society is we live in a culture that isn't looking very far ahead. I mean, they're just thinking about the next day, next week. We give them these 1-year numbers, but, we're talking about lifetime disease here. We're talking about 10-year event rate. So, sometimes personally, I think you should be commuting more the 10-year risk. I think the other thing that we do, which is not good, is we talk about relative risk, and we really need to be communicating absolute risk. That's the general guidance. And one of the other problems is that there are a lot of people out there who are anumeric. They don't really, know numbers that well. And so we need some better diagrams, like here's 100 bodies and here's the 10 of them over 10 years that will have had an event. We need to do better in communicating using visuals and things like that. And I do agree, Manesh, we also need to develop tools, and we're working on these that take into account, the patient's preferences about all these different kinds of events so we can optimize the outcome that they want to optimize. Well, thank you for joining us today, Manesh. Always great chatting with you. Been a great conversation. I hope we shed some light on the need to have some safer alternatives, why we're studying these alternatives, and what we can hope to learn from some of the big trials that are going on right now. Thanks for joining us.
We hope you found this podcast useful and educational.